evening, everyone, and welcome to today's wonderful evening. We have Dr. Dhairya, one of the NEET PG Topper, and doing his DNB General Medicine. Please welcome Dr. Dhairya. And we have Deepak Pahrot, Jitendra Verma, and many more who are all online. So, Dr. Dhairya, you are from which place, and what is your rank in NEET PG, and a little bit more about you?
Yeah, so hi everybody, I'm Dr. Dhairya. I think I have already spoken to a lot of you earlier. So I had taken a lecture 5-6 days back, which I think a lot of my students have attended, and I got a lot of nice comments for those. So thank you very much for that. I'm doing my DNB in general medicine. I had a rank of 4,800 in NEET 2020, and medicine is amazing, honestly.
Great. So a lot of students often ask a question as to, is it DNB or MD? DNB or MD, which is better? So what is your advice to all of them, Dr. Dhairya?
The best advice I can give is to speak to the residents that are working there. So I had the same dilemma whether or not I should go for a inferior MD or a better DNB academically. Ultimately, my decision was that medicine is going to be about what I learn and not about where I got my degree from. So at the end of the day, if I had to choose between a subpar MD or a good DNB, I'm definitely going to take a good DNB, and that was my decision. Definitely, I had to worry a lot about this. I thought about it a lot. I spoke to 20 people before I made this decision, but I'm very happy with my decision. And DNB also makes it easier for me to pursue my super specialty eventually. So,
Absolutely.
worth considering.
So it's a very good advice to all the students that once upon a time, there used to be a great differentiator between MD or DNB, DNB or MD, and people who do DNB, people think that it is very difficult to clear DNB. But honestly, as Dhairya rightly said, if your heart is for a particular specialty, there is no need of compromise, because MD, at the end of counseling, you may not be able to get in the right place with the right group or the right hospital environment. So instead of that, doing in a very good place with a lot of case material, doing the DNB is many times much worth than doing the MD per se. So that's a wonderful point. So let's make the great.
I would also like to add to that. If people say that DNB is a little more difficult to pass out of, then it also makes more educated doctors. So ultimately, the more you study, the more you know about your subject, and that is always good for your future. So I don't think a difficult exam should be a deterrent to somebody who has to do their specialty. It's not worth giving up on your specialty for an MD degree.
Absolutely. That's a great point. DNB versus MD, if you say, ultimately, Dhairya is a classical example. Getting a good rank, he has a choice in joining MD anywhere, but he had chosen the DNB because he wanted to do the DNB General Medicine in the best place. So let's make the great beginning, doctor. Today, we have 40 OPD cases, 40 clinical cases in the OPD. Dr. Dhairya is going to clear one case after the other and going to tell us 2 to 3 very important points. At the same time, Lokesh Kumar, Janil Patel, Deepak Pahrot, Jitendra, and everybody, I request all our audience to feel free to shoot your points, your audio, your diagnosis, etc. Because this is supposed to be the most interactive, wonderful evening of learning. Great. So let's make the great beginning, doctor. A 36-year-old woman has severe burning chest pain radiating to the neck, and the pain occurs particularly after meals, especially when she lies down, not precipitated by exertion, and her serial ECG and troponin I are normal. And what is the best next step is the question.
So, when I think about this question, the first thing you notice is that this is a 36-year-old lady. Now, at 36 years old, your cardiac issues are less likely to happen. I'm not saying it won't happen absolutely, but a 36-year-old lady probably has a more higher factor of stress, hectic lifestyle, and the way she's describing her chest pain as burning, especially after meals and especially when lying down, gives a very classical history of GERD, or maybe even a peptic ulcer disease, or maybe something else that is related to the gastrointestinal system more than a cardiac issue. I'd say that in this case, we would start a proton pump inhibitor, omeprazole, something like that. Monitor her for some time. Hopefully, the symptoms will reduce. Maybe give an antacid. Uh, if the symptoms persist even after that, then we'll have to evaluate for further causes. Maybe for Helicobacter pylori. Maybe we'll have to consider a endoscopy. Maybe we'll have to evaluate the cardiac status further. But at the start of this, in the first visit, it's definitely worth just giving a proton pump inhibitor for symptomatic relief, some antacid for symptomatic relief, and see how she progresses. Yeah.
Absolutely. So, in fact, angina pectoris, the characteristics are a substernal location precipitated by exertion, relieved by rest, or nitroglycerin is a classical nature. But one important point we need to remember is very commonly asked in the entrance exam. There is chest pain, but chest pain worsened, not improved. Worsened by giving nitroglycerin. What is the diagnosis? Is the favorite question of the examiner. Always we should remember hypertrophic obstructive cardiomyopathy is a classical scenario where if you give nitroglycerin, which is a vasodilator, then that will make the preload to the heart, decrease the preload to the heart, and that will make the left ventricular size become smaller, and a decreased size of the left ventricle will increase the touching between anterior mitral leaflet and the interventricular septum and worsen the left ventricular outlet obstruction, and that will worsen the angina. So the only situation where nitroglycerin, instead of relieving the chest pain, it worsens, you should always think and remember HOCM is what I want to underscore. Now, doctor, the next question. A 56-year-old man, chest pain of 2 hours duration, his heart rate is 42 beats per minute, sinus bradycardia. Actually, I thought of first presenting you the ECG.
While just stopping the question right here, just the ECG, we can classically very easily notice the most important factor here that should catch every single doctor's eye. That is the ST elevation in 2, 3, and AVF, very classical of an inferior wall MI. At the same time, patient is also having reciprocal changes in lead AVL, in lead V2, V3. Those ST depression are due to reciprocal changes. Essentially, there is ST elevation in the inferior leads, which is causing ST depression in the other leads. This is very, very classic of an inferior wall MI. There is no doubt about the diagnosis. The patient has to be thrombolized. That's about it.
Absolutely. And also, if you take between two QRS complexes, you can count 1, 2, 3, 4, almost 5. So that is the reason it is 300 divided by 5.
Sinus bradycardia is present. Sinus bradycardia can probably also be due to the inferior wall MI. This I don't expect to be anything else. This is a very classical inferior wall MI.
Absolutely. So that's wonderful. And another important point in the case of the inferior wall MI is a very important point to note in the clinical practice is whenever the anterior wall is involved, that leads to development of pulmonary edema. So when pulmonary edema is there, you should not overload with fluid. You should prevent the fluid overload. Whereas whenever the inferior wall MI is there, then you need to give a generous bolus of fluids in order to increase the preload to the heart and increase the inotropic state of the heart. So that is the main difference between the inferior wall MI management versus that of the anterior wall MI, where there is a pulmonary edema. Now, a 59-year-old diabetic woman, acute anterior wall MI, She gets into argument with her husband and complains of chest pain. Her initial ECG shows no ischemic changes, but cardiac troponin I are drawn and mildly elevated at this time. So, what is the best next step?
So now for this woman, the first thing you notice is that the age. So compare this to the earlier woman, she was 36 years old. This one is 60 years old almost. So at the same time, she's also having diabetes and she had a recent MI. This is a very, very high risk of a reinfarction. We have to think about this as a reinfarction. We have to perform serial ECGs. We have to get CKMB. CKMB is the marker of reinfarction. Now, I don't think troponins are relevant here because troponins are going to be elevated even because of the prior MI. So 5 days later, I don't think troponins matter that much. Troponin levels are high for at least 2 to 3 weeks, if I'm not mistaken. Uh, Cardiac CKMB, that is creatine kinase of the MB type, is the specific marker for this thing. Yeah, so I would perform serial ECGs, wait for ischemic changes to show up, and I would get a CKMB level.
Very good. That's a very, very important point. So troponin levels often remain elevated for about 7 to 10 days. So that is the reason they are not often used to diagnose a reinfarction. That is a carry-home message in this very important question. Now, a 59-year-old male smoker has a severe substernal squeezing chest pain, 30 minutes in duration, given sublingual nitroglycerin, and his BP is 110/70, heart rate is 90, ECG is normal. What is the next best step?
This patient is giving a very classical history of angina. There is nothing more to be done. Start antiplatelet. Consider starting atorvastatin, rosuvastatin. In any case, angina. Start aspirin.
Okay, that's good. So aspirin. In fact, one of our cardiology professor used to give a very favorite statement. As cardiologists and neurologists, ultimately there are only 2 to 3 decisions: thrombolyze, no thrombolyze; aspirin, no aspirin. So that is the reason aspirin is all that wonder drug that comes handy in the ICCU. So that's right, absolutely antiplatelets. So the aspirin is the first agent that should be used after oxygen and nitroglycerin. It's called MONA. The treatment is called MONA. O for oxygen, N for nitroglycerin, and A is for aspirin, and M is basically morphine. So that's a point you need to remember. Whenever there is a acute anginal episode. Now, doctor, a 55-year-old, severe congestive heart failure, impaired systolic function. So which drug would most likely lower his risk of mortality?
So for reducing mortality, there are only 2 proven treatments. That is your ACE inhibitor, ARB, and your beta blockers. So that's the answer here.
So out of all the armamentarium of drugs, only 2 drugs are known in multiple multi-regressional studies that decrease the real mortality. That is ACE inhibitor and beta blocker, which is available over here. That's right. Now, a 55-year-old, severe congestive heart failure, impaired systolic function. What is most likely to might have caused this congestive heart failure?
So for this patient, let's go through all of the points one by one and decide what the right answer is. So let's go with rheumatic heart disease first, because that is the easiest to rule out here. Rheumatic heart disease does not present at 55 years of age. Rheumatic heart disease will have a long-term history, and if at all a question of RHD is asked in NEET, they'll also give a history of pharyngeal infection, a history of acute rheumatic fever, rheumatic carditis, anything else, and the age would be maybe 25 at most, maybe 20 years, maybe 15 years. A 55-year-old person should not have rheumatic heart disease. Alcohol causing dilated cardiomyopathy, very possible, less likely, because the simple reason that the other 2 options are much more likely in this age. Among diabetes and atherosclerosis, both of them extremely likely to cause this kind of impaired systolic function. Just that from clinical practice you come to know atherosclerosis more common than diabetes in this case. I would go with B.
Good. So, and we need to remember, if we take congestive heart failure, it is being divided into systolic dysfunction and diastolic dysfunction. A lot of times what happens is, congestive heart failure, we go by the benchmark of 2D echo and look for the EF, ejection fraction. And if it is a diastolic dysfunction, then EF will be normal. Whereas if it is a systolic dysfunction, the ejection fraction is typically decreased. So a diastolic dysfunction with a normal ejection fraction some people have, where the heart has a difficulty to get filled. Filling of the heart is a big problem. And the only treatment that we give in the people with diastolic dysfunction is to give the drugs, that is the diuretics, are the main stay of the therapy in case of the diastolic dysfunction is what you need to remember. Now, doctor, and the most common cause of the CHF with systolic dysfunction will be in ischemia. And that is often because of the coronary atherosclerosis. Now, doctor, a 75-year-old chest pain with exertion and has been, and on examination, harsh systolic murmur, and this is the 2D echo in the parasternal long axis view, which is typically showing the classical parasternal long axis view. You can see the interventricular septum on here. And this is the left ventricular outflow tract. And here you can see a severely stenotic aortic valve. And typically the blood will be flowing from the left atrium through the mitral valve into the left ventricle. And from the left ventricle, it will be flowing through the aortic valve into the root of aorta. And you have the interventricular septum over here. So here it is a significantly stenotic valve. So now what is the best therapy for this, doctor?
So first, I'd like to say that 75-year-old man, that should give you a hint that degenerative aortic stenosis is very common in older people. Beyond the age of 70 to 75, degenerative AS is always seen. It is funny that I saw one patient of aortic stenosis in an old person today while I was in the hospital. So that's a good coincidence. And yeah, so this patient is giving a history of angina and dyspnea, angina and syncope, both of which are very classical of aortic stenosis. At the same time, you will have hypotension, and you'll have a systolic murmur. Systolic murmur will essentially be of the ejection type, which means that the murmur won't start at isovolumetric contraction. It will start when the aortic valve opens. So this is a very, very classical difference that is asked in NEET between a ejection systolic murmur and a pansystolic murmur, that the ejection systolic murmur will start after isovolumetric contraction, whereas pansystolic murmur will start during isovolumetric contraction. Am I right, sir?
Absolutely. In the mitral regurgitation, you have the pansystolic murmur. All regurgitant lesions at the AV valve lead to development of the pansystolic murmur. And pansystolic murmur, you don't listen S1, you don't listen S2. What you only listen is z, 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 like a honeybee. Z, z. So always such kind of pansystolic murmur of the MR typically has got a low amplitude and a high frequency. Always in the stethoscope, you have a bell and you have a diaphragm. So that is the reason the diaphragm is the one which is typically used to listen to the pansystolic murmur. Another thing is the pansystolic murmur of the mitral regurgitation typically radiates into axilla. So that's very important. Whereas ejection systolic murmur of the aortic stenosis, the radiation is more into the neck fundamentally. And in aortic stenosis, one more important point that you have is typically pulses at tardius. There is a slow rising pulse, which is very classical. And a lot of people who have aortic stenosis are often asymptomatic. Even until the age of, suppose if they have bicuspid aortic valve, they all come in an asymptomatic way. But typically, when you do the when the person develops hypertension, क्या हो जाएगा? एक तरफ से aortic stenosis के वजह से the left ventricle is having already a lot of strain to push the blood. दूसरे तरफ से हाइपरटेंशन भी ऐड हो गया, सो दोनों ऐड हो गया तो लेफ्ट वेंट्रिकल बोलेगा ये क्या है, मैं two stresses I cannot take, only one stress I can take. So that is how the left ventricle will then fail. Then the patient becomes asymptomatic. So that is the reason the carry home message of the question is bicuspid aortic valve like conditions or any aortic stenosis, even until it is mild to moderate, the patient can be asymptomatic. And the moment the hypertension sets in, the essential hypertension, then the otherwise asymptomatic AS will then turn out to become the symptomatic AS is what we need to remember. So that's a point of interest. Now, a 55-year-old man, congestive heart failure, comfortable at rest, but become dyspneic even with walking to the bathroom. And he is noted to have a EF of 47%. So what is the accurate description?
Yeah, so first we would have to think about NYHA grades. So whenever you look at a clinical case like this, New York Heart Association has made a very easy to understand, very wonderful guideline to divide these cases. So there is NYHA grade 1. NYHA 1 would mean that patient gets symptoms, either angina, either syncope, either dyspnea, whichever symptom of cardiac issues he is getting. So NYHA grade 1 would be a symptom which is present when the patient is exerting himself too much. NYHA grade 2 will be when there is mild exertion. NYHA grade 3 would be at moderate exertion, and NYHA grade 4 will be when the patient is at rest. So did I mess up 2 and 3? I'm sorry. So grade 1 would be when he is doing extra amount of work. Grade 2 would be when the patient is doing a normal amount of work. Grade 3 would be even a very mild amount of work, and grade 4 would be symptoms at rest. So this is a very easy to classify way of and essentially a very useful way of classifying cardiac patients. So this patient with an ejection fraction of 47% not reduced, usually less than 40 to 45% would be called as a reduced ejection fraction. This patient fits into a diastolic dysfunction. In any case, when you look at these options, even if you're not sure what the cutoff is, at least the best idea would be to rule out options C and D, which make no sense in this patient. So if you're not sure where the cutoff is, at least you'll have a 50-50 shot at marking it correct.
Right. So the cutoff that Dr. Dhairya is saying is 40%. When the EF exceeds 40%, that is likely to be diastolic dysfunction, whereas the moment it is below 40%, we consider the possibility of systolic dysfunction. That's how the difference is between. Now, a 28-year-old woman with 2D echo shows is being shown. What is the murmur most likely to be present? So once more, we need to remember that here you are able to see a fish mouth appearance of the closely opposing mitral stenosis. And you can only be able to know you can judge the severity by using the color Doppler. So this is the case of mitral stenosis. Now the question is, what is the murmur, doctor?
So mitral stenosis, the murmur would be a murmur which comes in the diastolic period, first of all. So whenever you have a valvular heart disease, you have to first think whether or not it's a systolic or a diastolic murmur, because that itself is going to make your options, make it easier to rule out essentially. So first thing is that a mitral stenosis murmur would be a diastolic murmur. The second thing is that the murmur would increase when the atria are contracting. So the murmur would be less or even absent at the time when the atria are just relaxing, and during joint diastole, the murmur would either be very little or it would be absent, but the murmur would peak when the atria contract. So it would be at the end of diastole of the ventricles towards the essentially it would be a mid diastolic murmur with a presystolic accentuation. That's how classically we define a mitral stenosis murmur. Honestly, the easiest way to understand how this murmur works is to try to think about a heart, try to think about the valve, and try to think when the murmur would peak.
Absolutely. And in fact, diastolic rumble that you listen in case of the mitral stenosis, Typically, it has got a high amplitude, low frequency. That is the reason always we should use the bell to listen. Point number one. Number two, it is a localized murmur. Unlike mitral regurgitation, you will go through everywhere of the patient. You will be looking in the axilla, you will be looking everywhere and undress the patient virtually. Whereas in the case of the mitral stenosis, you don't need to do anything. Just go and stand behind the patient. Just use your fingers to feel where is the apex. The moment you felt that apex, then use your bell. Always when you use the bell, you are trying to listen a high amplitude sound. Don't press it. Just lightly touch it. Then what will you listen? Lub, S1, dub, S2, drrrr is the rumble of the mid-diastolic murmur. Lub, dub, drrrr, lub, dub, drrrr. In fact, that drrrr become accentuated before the systole. So before the S1, it become accentuated, which is very classical feature. But the moment atrial fibrillation sets in, you lose that presystolic accentuation.
Accentuation is lost. Yeah.
Accentuation is lost. So first of all, why there is a presystolic accentuation? This is a very important point many times we discussed. So typically this is happening in diastole. So if you look at the ventricular diastole we are talking about, right? It has got 3 1/3. First 1/3, second 1/3, third 1/3. First 1/3 में क्यों होता है the diastolic flow? Because before opening of the valve, mitral valve, the atrium is fully pregnant with blood, and the ventricle has completely relaxed. So there is a pressure difference, and that is a driving force during the first 1/3. Second 1/3 क्यों होता है? The atria are sitting at a higher level than ventricle. Newton's apple is falling down because of gravity, because of the gravity. Last 1/3 क्यों होता है? That is the time where the mother-in-law, atria, will wake up and say, "बहू मुझे कॉफी लाना, चाय लाना," बोल के, इसमें शक्कर नहीं है, क्यों ऐसा बनाया बोल के, she started shouting. So the atria actually contracts and pushes during the last 1/3, and because of that there is a stenotic valve. The husband is a lazy fellow, and the wife is trying to push him to the office in the morning, last 1/3 way. So that lead to the accentuation of the mid-diastolic murmur of the mitral stenosis is what we need to remember. Atrial fibrillation, once it sets in, then the presystolic accentuation become lost, is the point you need to remember. That's great. Now, a 48-year-old woman feeling giddy, dyspnea, systolic BP 75/48. What is the most next important step? I think ECG presented. Yeah.
So what do we see in the ECG first of all? So when I look at a ECG, first thing to see is the rate. So this patient's heart rate is high. If I had to count, I would say that this is maybe around 120 to 140, roughly. Just looking at it, I can say. Secondly, I'd also like to point out that there are no P waves. P waves are absent. Absent P waves along with an increased heart rate starts telling me that this might be an atrial fibrillation. That is confirmed when you look at the RR interval. So as you can see, RR interval is not constant at all. It is broad somewhere, it is narrow somewhere. But another thing to note is that the QRS morphology is narrow. The QRS is not prolonged. It is not broad. It is a normal looking QRS with an irregular RR interval and absent P waves. This is very classical of an atrial fibrillation. When we think about atrial fibrillation as a condition itself, acute atrial fibrillation, then in a stable patient there would be two schools of thought as to how you'll treat this patient. There would be rate control and rhythm control. Not going into details of either here, but essentially rate control means that you would want to bring the heart rate down below 110, below 100, so that the ventricles are able to collect an enough amount of end diastolic volume to push. Rhythm control would be trying to convert the patient back into sinus rhythm. So these are the two normal ways to approach an atrial fibrillation. However, the important point to note in this patient is that her BP is falling. She is also having symptoms of hypotension. This is an emergency situation. Patient has to be cardioverted.
Very good.
Uh,
So the DC
going at
cardiovascular.
Going at the other options, intravenous digoxin, it is an inotrope. It is used in atrial fibrillation with heart failure. That is the only indication of digoxin at the current time. DC cardioversion, as I said, is the correct answer here. Vagal maneuvers, if you are suspecting a paroxysmal supraventricular tachycardia, and diltiazem is again a AV node blocker that will also be used in a supraventricular tachycardia. Yeah.
Absolutely, absolutely, doctor. So this is after giving the DC cardioversion, the patient's sinus rhythm normalized along with appearance of the P waves, regularity of the QRS interval, and the patient's rate is also restored. Now, a third-year medical student reviews the charts of a lot of patients having atrial fibrillation, taking Coumarin. So, out of these, case 1, case 2, case 3, case 4, which case do you want to discontinue the anticoagulation in a case of atrial fibrillation?
Yeah, so there is something known as a CHA to DS2 VASC. That is a criteria which is for the risk of stroke in patients with atrial fibrillation. So C means heart failure. H means there is an age criteria. There is diabetes. There is sex category. There is a previous history of strokes. Upon looking at everything, you have to calculate the score. But in general, if the patient has all of these features, if he is more than 65 years of age, if the patient is a male, if the patient is especially more than 75 years of age, then you have to think that his CHA to DS to VASC score is high. Uh, Among these things, the 45-year-old male who has a family history only, but the current problem is that he is in atrial fibrillation. If at all if at all rhythm control is not possible in this patient, he should be a prime candidate for rhythm control first of all. But if rhythm control is not possible, if he's not getting reverted, or if he's going back into atrial fibrillation even after rhythm control, then you can leave the patient with rate control. There is no need to give anticoagulation. Looking at all the other patients, 60 to 75-year-olds, very likely to have more complications, a higher risk of stroke. Uh, Especially the 75-year-old patient, out of the question. The 52-year-old is having orthopnea and PND. He has very classical features of heart failure, which is one of the indications for continuing your warfarin. Yeah, so that's about it.
Absolutely. So, in a case of the lone atrial fibrillation, where the CHARD S2 score, where C for congestive heart failure, H for hypertension, A for age, more than 75, D for diabetes, and S is the prior stroke. And the score less than 2 qualifies it as a lone atrial fibrillation and a low risk for stroke. So not much of use of anticoagulation, because anticoagulation is a double-edged sword with the chances of the bleeding episodes also is a point of interest here. Now, a 59-year-old chronic atrial fibrillation placed on warfarin, INR is 5.8, asymptomatic, no overt bleeding. What is the best management?
So this patient is clearly having an increased INR. He's reacting too much to warfarin. The best way is to stop warfarin for a week. One thing to remember is that warfarin takes about 5 to 7 days to start acting. In that time, warfarin also precipitates a procoagulant state, which is a very important point to note, that when you are starting warfarin, you have to overlap it with other anticoagulants, maybe with LMWH, maybe with Novax, that is novel anticoagulants, dabigatran, rivaroxaban, anything else. Cannot start warfarin alone. As a NEET MCQ, you should remember that warfarin is a vitamin K antagonist, vitamin K epoxide antagonist, which so there will be protein C and protein S deficiency in the acute term, and in chronic term there would be a deficiency of factors 2, 7, 9, and 10. But because protein C and protein S deficiency is precipitated first due to them having a lesser half-life, warfarin will cause an initial procoagulant state and will actually worsen your thrombosis, which will worsen your clots, which will worsen your symptoms. You have to overlap warfarin with anything else. Uh, yeah, so
Yes.
for this patient who is having a high INR with no other symptoms, best thing is to hold warfarin. Eventually, maybe you have to reduce the dose of warfarin. In these times, it is even better to change the patient out of warfarin into better anticoagulants that are now available. Uh, yeah.
Very good. So generally, whenever we give warfarin, it is 2 to 3. 5 point is significantly elevated, and lucky that there is no overt bleeding yet, but there is a chance, so that's the reason we need to hold it. Absolutely. A 45-year-old woman, giddiness, pounding of the chest, fatigue of 3 hours duration, BP is 110/70, and her ECG is being shown to you, and the heart rate is significant, and physician counsels the patient regarding cardioversion, but the patient declines. And what is this ECG? Very important clue that it is giving, and how do you manage is a very important question.
When you see ECGs like this, the first thing you look at the AVR, you think this is a ventricular tachycardia. VT would be the first differential that you have to rule out in this patient. Ventricular tachycardia, very important. But then you look at it in detail and you realize that the RR interval is not regular, even though the QRS morphology is the same. So this does not look like a VT. It also does not look like a TDP. It is definitely not a ventricular fibrillation. The patient is too stable for that. So at this point now you have to think that this has to be a supraventricular rhythm. Supraventricular rhythm, when you start thinking, then you would think this is an SVT with aberration. An SVT with aberration then should have other features of SVT. There should be a regular RR interval, which is again not present. So this again brings us back to that same point, that an irregular RR interval in this patient is an atrial fibrillation. An atrial fibrillation in which the patient is still hemodynamically stable. However, then you have to think that there is something else going on along with the atrial fibrillation. This patient has a, I assume that's a delta wave. Am I correct?
Yes. Yeah,
Yeah. So
absolutely.
there is a delta wave in
Case of
lead.
WPW. It's a case of WPW, and WPW syndrome with the presence of high ventricular rate. So how do we manage is the question. So generally, when the SVT is there, commonly what do you give? If at all there is any SVT, you want to prevent its transmission into the ventricle, right? Into the ventricle. So in order to prevent that, you need to use some drug that increases the refractoriness of the AV node. And that is the whole purpose of giving digoxin. But what is the problem if there is any AF with the WPW syndrome? Why you cannot give digoxin? The reason is simple. Digoxin, basically in WPW, the conduction from atria to ventricle is happening through the aberrant pathway. So obviously, if you try to block the AV node, always say atrial rhythm disturbance has a choice to pass either through the AV node or through the aberrant pathway. So it depends upon which is more permitting it to travel. So abhi kya ho gaya? Regular wala, if there is no WPW, then if you block the AV node, you can prevent the SVT from going into the ventricle, right? Whereas if it is an aberrant pathway, then if you happen to give digoxin, what will happen? You are blocking the AV node and encouraging the further encouraging the transmission from atria into ventricle through the aberrant pathway. So that is the reason digoxin is permitted to be given to control the AF ventricular rate in any situation, but contraindicated if there is a WPW. So you need to use such a type of antiarrhythmic drug, which in fact will come and block the aberrant different pathways selectively. And that is what the procainamide will be doing. So that is the reason to control the ventricular rate of the AF in a case of WPW, the drug of choice is procainamide, and regular wala AF in a normal heart, which is structurally normal, no aberrant pathways. Then the digoxin is the choice. That's a point of interest here. That's good. Now, doctor, a 42-year-old overweight but otherwise healthy woman, right upper abdominal colicky pain 45 minutes after eating fried chicken, and there's a nausea, vomiting, and increasing pain. What's your diagnosis, doctor?
So now, right upper abdomen, you have to think about. I mean, this is very basic MBBS level stuff. You have to think about what organs are present under the skin at this stage, at this area. So right upper abdomen, you would think of your liver. You would think of your gallbladder. You would maybe even consider the head of pancreas at some point. Even though that is more epigastric, but maybe it might cause right upper quadrant pain, and on top of that you would also have to think of maybe the right kidney if sometimes. So in this patient, she's saying that after taking a fatty meal she is having complaints. This is very classical of a gallbladder issue, probably cholelithiasis, probably cholecystitis. In that case, gallbladder issues, then that's about it. Very straightforward.
Absolutely. Now, with regard to H. pylori, what is the most accurate statement, doctor?
I think the slide hasn't changed, sorry. Sorry. uh, So now I'll just go option by option because I'm not this thing. So it is more common in developed than underdeveloped countries. That is absolutely wrong. H. pylori is an infection. It is more common in underdeveloped countries. It is also very common in our country. It is associated with the development of colon cancer. That's again not true. So Helicobacter pylori, two interesting factors about it. It reduces the risk of esophageal cancer. It increases the risk of gastric carcinoma. Most importantly, it increases the risk of gastric maltoma, that is mucosal associated lymphoid tissue tumors. Option C, very easy to know that it is true. H. pylori associated with ulcers, peptic ulcers, and it is not sexually transmitted. So that's about it. Remember that H. pylori is not a bacillus. H. pylori is a gram-negative spirochete. Uh, that's also sometimes asked. Diagnostic test would be a urease breath test. That's also sometimes asked. Yeah,
Absolutely.
that's about it, I think. Yeah.
45-year-old man was brought to the ER after vomiting bright red blood. He has a blood pressure of 88 by 46, heart rate of 120. What is the best next step?
So this patient now, clearly a low blood pressure, clearly a high heart rate patient is going into shock. Management of shock, you cannot go slow. You have to be very fast. Start IV fluid resuscitation, start blood transfusions. Everything else is also important. All of that will come later.
Absolutely. Now, which of these patients do you want to post them for endoscopy, doctor?
A 65-year-old man with new onset of epigastric pain and weight loss. Yes, I would like to go for this patient's endoscopy. 32-year-old patient whose symptoms are not relieved with ranitidine. That's probably related to stress. No need. 29-year-old with H. pylori. Again, that's a young patient. He's a known H. pylori positive. He must have peptic ulcer disease or something. You can just treat the H. pylori. You can give him this thing. Antacids, you can give him pantoprazole, and you'll see later. Woman with right upper quadrant pain. This is the same woman we saw earlier. This is gallbladder related issues, so no point in doing an endoscopy. I would go for option A. No question asked.
Absolutely. And also the weight loss in a 65-year-old is in more of a possibility of a gastric outlet obstruction. So that is the reason we go for endoscopy. Now, a 24-year-old man developed seizures, emergency, following an emergent splenectomy after a car accident. His sodium is 116, corrected value is 120 over the next 3 hours with the hypertonic saline. So what factors most likely may be responsible for hypernatremia here?
So this patient, very classical of SIADH, that is syndrome of inappropriate ADH secretion, seen in most common cause of SIADH really is nausea. It is also due to pain. It is also due to any stress at all, due to surgeries. So anything at all will cause an increased ADH. Answer is option A.
Absolutely. So SIADH presents with hyponatremia as a presentation. And one important thing on the SIADH is it is a diagnosis of exclusion. That is, there should no renal disease, there should be no liver disease, there should be no thyroid disease, and there should be no adrenal disease. Without any of these disorders, without any reason, inappropriately अगर ADH का production हो रहा हो, इसको कहते हैं SIADH. Then the second important point about SIADH. SIADH is a situation of two things in common. There is a low serum sodium, at the same time there is a high urinary sodium. So now why there is a high urinary sodium in SIADH? The reason is, once ADH is excessively produced, what will it do? It is anti-diuretic. So when it is anti-diuretic, what it is causing? It is preventing diuresis. That means water is retained in the body. So retained water will increase the plasma volume. Increased plasma volume, what does it do? It will stretch the atria. And the atria which are stretched, what will they produce? They produce atrial natriuretic peptide. And it is the atrial natriuretic peptide which is the one which typically leads to the urinary sodium levels to increase, is what we need to basically remember. So a lot of people miss this fact that why urinary sodium is increased. The urinary sodium is increased mainly because of the atrial natriuretic peptide is what we need to remember. And another thing is, the patient should be euvolemic before you consider the diagnosis of SIADH. Suppose if the patient is dehydrated or if the patient is having edema, then ADH production is obviously appropriate only. There is nothing inappropriate about it. So that is the reason in a euvolemic patient, without renal, without liver, without thyroid, without adrenal disease, the one who is showing a low serum sodium and a high urinary sodium defines the clinical diagnosis of SIADH is what you need to classically remember. Now, doctor, a 56-year-old, fatigue, weight loss, he's a day laborer and he smoked cigarettes and serum sodium 126, digital clubbing, potassium is 6.7, bicarbonate chloride are low, and there is a low to normal blood pressure, and there is also skin hyperpigmentation. What is your diagnosis?
So, everything here points us towards a mineralocorticoid deficiency, a glucocorticoid deficiency. So essentially hyperpigmentation and low to normal blood pressure are indicative of a glucocorticoid deficiency, whereas a dyselectrolytemia that this patient has, that is a low sodium with an increased potassium and low bicarbonate, essentially means that the patient is having metabolic acidosis. All of this very classical of adrenal insufficiency. Option D, that would be your Addison's disease.
Absolutely, absolutely, doctor. Now, 83-year-old woman. So, Kirtu, Deepa, Chandani, and many more who are all online. Keep punching your answers, doctor, and also the points that come to your mind, please type it into the chat window. Yes. So, doctor, the next question. 83-year-old, headache, mild confusion, and medical history is remarkable only for hypertension, well controlled on hydrochlorothiazide, sodium is 119, plasma osmolarity is 245, she appears to be hypovolemic. What is the best initial therapy?
So now, because the patient is hypovolemic, you will now have to give the patient water correction. There is no need to correct the sodium levels aggressively, especially because the patient is asymptomatic. Hydrochlorothiazide causes hyponatremia because it causes excretion of very concentrated urine, so that is expected in a patient. At the same time, this patient who is having clinical hypovolemia, here the clinical hypovolemia is the indication to correct the fluid loss. It is not an indication to correct the salt loss. I would give normal saline, that is 0.9% saline, and make sure that the patient comes out of dehydration. The sodium levels, as long as asymptomatic, as long as mild, do not actually need to be corrected. A similar question with the patient having hyponatremic seizures would be an indication to correct aggressively with 3% saline. However, this patient who is only hypovolemic, there is no need to correct the sodium levels. Please do not correct sodium levels here.
So this reminds me, one of our senior resident from PGH Chandigarh, Dr. Anand, when we were when we were postgraduates. अरे नॉर्मल सेलाइन लाओ बोले तो वो बोलता है कि भाई नॉर्मल सेलाइन क्यों पूछ रहे हैं, व्हाट इज एबनॉर्मल सेलाइन बोलो. So there is nothing called abnormal saline, right? So one of my favorite questions you will remember is how many milliequivalents of sodium is there in the normal saline and how much is there in the hypertonic saline. It's very important to remember. So you need to remember three numbers: 5, 1, 5, 4. 1 plus 4 is equal to 5, right? So you can remember 154 here, and you can remember 514 here, milliequivalents over here, right? So milliequivalent composition of the sodium per liter in normal and abnormal saline. Now, a 58-year-old man, lengthy colon cancer, first post-operative day, significant hyponatremia with 128 milliequivalents per liter, and it is the IV infusion of hypotonic solution you suspected. Which laboratory findings say that this is because of infusion of hypotonic solution?
So now this patient is a post-op day 1. The first thing that you should think is that this patient is again in SIADH that might be causing a low sodium level. In that case, there would be no need to correct it. However, then the MCQ itself tells us that it might be due to an infusion of hypotonic solution. Now the point is that you always have to compare your serum osmolarity with your urine osmolarity in order to prove or disprove this thing. So in SIADH, as we had already pointed out, that the urine would be more concentrated. That means that the urine osmolarity, the urine sodium will be high. A high urine sodium would indicate SIADH postoperatively, which would be expected in this patient, which would be normal in this patient. However, this patient, if you want to prove that this patient is having hypotonic solution excess, then option A is ruled out because that would be in SIADH. Option B is similarly ruled out because that is again SIADH. Option C, yes, hypotonic solution. As we had established earlier, that for a diagnosis of SIADH we would need a euvolemic status. However, this patient who has a low serum osmolarity probably has a hypotonic excess. Serum potassium of more than 5 actually does not matter in this patient. A post-operative patient can have 100 causes of elevated or decreased serum potassium levels. It's not relevant to this point at all. So option C is the correct answer.
So Keertu has rightly answered it as C. Deepak and Sanat Chavan had been clipboard in this particular point. But the very important point, as rightly said by Dr. Dhairya, is SIADH is more urinary sodium, increased urinary sodium, but hypotonic solution is favored over here by the serum osmolarity being low is the point of interest here. Now, 59-year-old man complains of severe chest pain radiating to his back. The brachial pulses appear unequal. He is hemodynamically stable, and actually his chest radiograph is shown. Yes, doctor. What is your comment?
So going back to this patient, can we go to the question, please? So
Yeah.
the first thing you see, 59-year-old man who is complaining of chest pain. The first and the most important thing is the myocardial infarction. However, you have to rule out the other emergency conditions which are associated with chest pain. The other two are pulmonary embolism and aortic dissection. So once you are confident enough in your abilities that, and obviously a tension pneumothorax. So these are the 4 emergency situations that you have to rule out in chest pain. Once you're confident in your abilities that the patient does not have any of these 4 conditions, then you can relax and you can try to investigate further. You can send the patient for whatever investigation, you can send blood reports, but these four things have to be ruled out first. So now when this patient is coming with a severe chest pain, you have to ask for an ECG. Whether or not you suspect an MI is irrelevant here. ECG is always a must. Secondly, you see that this patient's brachial pulses are unequal. That means essentially what that means is that the right side of the right hand is getting more blood, or more forceful blood than the left hand, which means somewhere or the other there is some blood that is leaking out of your aortic circulation. That is very diagnostic of aortic dissection. This patient has an aortic dissection. You have to now find the Stanford classification of aortic dissection, that is whether it is a Stanford A dissection or a Stanford B dissection. Diagnosis is CT.
Absolutely. So this is a classical case of widened mediastinum, loss of the contour of the aortic knuckle with a globular heart, which typically suggests the presence of a aortic dissection is what we need to remember, and CT chest will prove that. Now, a 45-year-old woman with a new onset aortic regurgitation, and the imaging has been shown to you, and based on this, what is your diagnosis, doctor?
Uh, so new onset aortic regurgitation patient has a aortic dissection again. Uh, can I go back to the options, please?
Yeah.
Uh, yeah. So because this is a Stanford A kind of dissection, answer is surgical correction.
Absolutely. The moment the ascending aorta is involved, doctor, it involves the aortic valve. So, unless you do the surgical correction, only medical management will not do if there is an involvement of root of aorta and the aortic valve is the principle of management. Now, a healthy 75-year-old man, ultrasound exam suspected gallbladder disease, a 4.5 centimeter abdominal aneurysm of the aorta is found. What is your management, doctor?
So less than 5 centimeters of the aneurysm, you don't have to surgically correct it. You can observe the aneurysm for growth. You can observe the aneurysm for signs of for a high risk status, and you have to look at the patient's age. That is a 75-year-old man. He's not going to be able to tolerate surgery well. So as far as you can avoid it, you should avoid it.
Absolutely.
We should just get serial ultrasounds. And another thing to note is that 75-year-old patient, uh, abdominal aortic aneurysm, a common diagnosis would be syphilis. A close second would be Marfan syndrome. uh,
Actually, most of the times, the way abdominal aortic aneurysm is being discovered is in a similar way we discovered a lot of times. We do ultrasound for some reason, and in elderly man because atherosclerosis is evidently there in most of the people, and that will be most of the times responsible for an asymptomatic abdominal aortic aneurysm. So, as Dhairya rightly said, once it is less than 5 centimeters, there's no point, and more than 5.5 centimeters is an indication for surgery. So that's a point of interest, absolutely. Now, a 45-year-old man, his father died of ruptured abdominal aortic aneurysm. He has a bicuspid aortic valve, and what is the right statement about it?
Pardon me, sir. Sorry, what was the question?
The question is, a 45-year-old man, his father died of a ruptured abdominal aortic aneurysm, and this guy is found to have bicuspid aortic valve.
So
What?
asymptomatic bicuspid aortic pulse should not actually matter with anything. So you can just ignore that. On top of that, aneurysms are usually not genetic. This is just nothing.
Absolutely. So bicuspid aortic valve is not per se a risk factor for developing aortic aneurysm. Absolutely. Now, a 32-year-old woman, 5-year history of HIV, CD4 count is 100. She is admitted to hospital with a 2-week history of fever, shortness of breath, and dry cough. So, what is the diagnosis and how do you confirm?
So now this patient with 100 cells per mmq, you have to think of tuberculosis in India. You have to think of other causes of pneumonia, PCP. You have to think of any other bacterial pneumonia. So on top of that, because this patient is having a 2-week history, that is a moderate amount of time, you should think of pneumocystis jirovachai, that would mean that you have to go for a silver staining.
Absolutely. The silver stain on sputum.
I would like to point out that HIV might be asked in NEET this year because there are some new changes that have come up. So the first thing is that your treatment in HIV now, the first line is tenofovir, lamivudine / emtricitabine and dolutegravir. That is your TED. Uh, at the same time, just a couple of weeks back, a new regimen got approved. That is your cabotegravir and rilpivirine, which is a 1 month
What is the spelling,
injectable.
doctor? What is the spelling? What are the two drugs?
CABOTE That is an integrase inhibitor, and rilpivirine, RILPIVIRINE. These are your injectable drugs taken once a month as complete ART. So HIV, very important topic this year. So is COVID. I expect questions to be asked from this.
Absolutely. In fact, I would be glad if Dr. Dhairya can take one of the opportunities, say 20-minute or a 30-minute review on the newer antiretroviral drugs for the benefit of all the students. We will try to have one session on a joint session on it is a learning for the for every one of us and a good revision also, as rightly said by Dhairya. These are the topics, COVID drugs. Today 2-deoxyglucose is being approved for the management. And what is the mechanism by which 2-deoxyglucose is working in corona? So these are all going to be the questions in the upcoming NEET PG exam. So there are many more questions, actually 50 questions planned, but a good discussion of 25 questions is all that makes all the difference. Now, I like to quickly ask Dr. Dhairya, there are 3 things that most students ask and love to learn from the toppers. That how do you used to manage the anxiety before exam?
So I think, sir, I've already taken a lecture on this exact topic 5 days back. It was a 1 hour long session that I think all of the students would be benefited from going through. As such, what I used to believe is that if I am anxious, I said the same thing that day as well. That if I am anxious while giving the exam, then I should also realize that everybody else has the same anxiety. So me being anxious is not putting me at a disadvantage. The most important thing is to not overexert yourself, because this is not a short-term race. This is a marathon essentially. So if you try to lose sleep, if you try to exert yourself every day, you'll eventually end up tired and you will not be able to perform at your 100%. The best thing is to make a short-term plan. The best thing is to believe in yourself essentially. So I think I have explained all of this in more detail, how I used to go through all of this. I think it would be worth for everybody to go through that session. I think
Absolutely.
somebody will
So,
help me
Dr.
out and
Dhairya,
introduce the
you
like.
studied undergraduation from which college, doctor?
So my UG was from JJ Hospital in Mumbai. I think it's a fairly well-known hospital. Yeah.
Yes, it's like a Makkah for learning. And
Uh, I'm very proud to say that
one very important question,
today is the foundation day of JJ Hospital. So uh, I'm
the
very proud
JJ
to say I
Hospital
am.
should be proud that their student is now the teacher for the entire world. And thank you very much for joining the session and being very supportive to all our students. And once more, I want to ask you another question. Of course, we will have many more sessions together because this
Absolutely.
program is going to be a everyday 10 p.m. live broadcast, all 365 days across the year. So that is the reason we'll have so many toppers on this forum, and we will have a discussion with of at least 30, 40 questions. So one question I want to ask you, Dhairya, were
Yes.
you a so-called Sinsiput, like Ossiput, Sinsiput student from the first year, very seriously studying with no girlfriend kind of a stuff, or you suddenly realize like Gautama Buddha in the internship and then started working for the entrance?
So honestly, I took full advantage of my UG. I had a lot of fun my friends were very close, and I used to go on trips, and I did not actually care about university exams that much. I always knew that NEET is the only thing that is going to matter in my life eventually. Honestly, I did not get a single distinction when I was in UG. That absolutely does not matter. What matters is your confidence, your preparation during NEET, because you don't get a seat based on your distinctions. You don't get a seat based on how many marks you got in a university theory paper. NEET is all about applying your knowledge you have gathered over the years, and that's where some people are just not able to cope with. Honestly, that's the gist of it.
Absolutely. That's a great point, Doctor. And Sanat, Rishabh, Keetu, Deepak, and many more who all joined for this wonderful evening with Dr. Dhairya, the general medicine. He's like Veda Vyasa. I have seen his video. Such a serene personality and with such a clarity. He was delivering the video. That video is uploaded in our YouTube channel. Please watch it. And tomorrow morning, that is every Sunday, 9 a.m., you have a live broadcast of the 200 MCQ full-scale grand test. Morning 9 a.m. to 12 p.m. Then 12 p.m. I will come down, and I invited Dr. Shraddha to discuss 100 questions in a question-answer format between teacher versus topper. So from 12 o'clock to 1:30, we have a discussion of 100 questions, and we'll take a half an hour break. And once more, 2 to 3:30, I invited another topper who is MS General Surgery, Dr. Vishnu Soni, to join for another 100 questions discussion. So this happens every Sunday, morning 9 a.m. to afternoon 12 p.m. It runs like a PowerPoint slideshow. And if you're there on the Incus app, you also have an opportunity to answer it like a quiz on the Incus app, all 200 questions. And let me tell you, NEET PG coaching for 1 rupee per day. We want all of you to take the best benefit of it. For next 3 years, you get an activation on both the web and also the app. Just for 999 rupees, you get 3 years activation with almost all 500 hours of session, live session with the NEET PG toppers. So see you all tomorrow evening, morning at 9 a.m. with the NEET PG Foot Scale Grand Test on Sunday. And thank you so much, Dr. Dhairya, and God bless you. And we wish to once more have many more sessions on the same floor. Thank you.
Absolutely. Thank you for having me. This was a lot of fun. Thank you.
Thank you.